In this first video, we will cover part 1 of the esophagus, obstructive and vascular diseases. We will go over mechanical and functional obstruction and their causes, followed by ectopia, and finally end with esophageal varices. So mechanical obstruction results from a physical obstruction. In the case of the esophagus, this can be to atresia or stenosis. Atresia is a congenital disorder in which the esophagus fails to canalize. The most commonly occurs at the tracheal bifurcation and is associated with the fistula connecting the upper and lower esophageal pouch to a bronchus or the trachea. The most common fistula type seen is when the proximal esophagus ends, or is atretic, and the distal esophagus connects to the trachea. When a baby with tracheoesophageal fistula swallows, the liquid can pass through the abnormal connection, leading to aspiration, suffocation, and pneumonia. Patients can also experience fluid and electrolyte imbalances. Stenosis is the other common cause of esophageal mechanical obstruction. The narrowing is typically caused by fibrous thickening of the submucosa, atrophy of the muscularis propria, or secondary epithelial damage. This is almost often caused by inflammation and scarring from chronic GERD, irradiation, or caustic injury, such as swallowing bleach. That's why it's very important if a person swallows bleach, you later go in with endoscopy to make sure that there is no stenosis. Patients will often present with progressive dysphagia, where they first have trouble swallowing solids and eventually will also have difficulty swallowing liquids as the narrowing worsens. So functional obstruction of the esophagus results from problems of dysmotility from discoordinated contractions or spasms of the muscularis. Achalasia is a common cause of esophageal dysmotility and can be primary or secondary. In primary achalasia, you get idiopathic failure of the esophageal inhibitory neurons. Secondary achalasia can arise in the setting of Chagas disease, in which the parasite T. cruzi destroys the myenteric plexus. T. cruzi can also affect the duodenal, colonic, and ureteric mesenteric plexi, in addition to causing cardiomegaly. Diabetic autonomic neuropathy, infiltrative disorders such as amyloidosis, malignancies, and sarcoidosis, in addition to lesions of the dorsal motor nuclei, can all result in an achalasia-like picture. In general, patients with achalasia will present with the triad of failure of the lower esophageal sphincter to relax, increased lower esophageal sphincter tone, and esophageal aperistalsis. So ectopic tissue can often be found in the esophagus. In general, ectopia is the presence of normal appearing mucosa in locations where it shouldn't normally be found. These are also called developmental rests. The most common site of ectopic gastric mucosa is the upper 1/3 of the esophagus, where it is often referred to as inlet patch. This is generally asymptomatic. However, if the gastric mucosa produces acid, you can end up getting dysphagia, esophagitis, or even Barrett's esophagitis, or rarely adenocarcinoma. The principal vascular disorder of the esophagus is esophageal varices. These form in the presence of portal hypertension, whereby collateral channels will shunt portal blood into the caval system. The collateral veins enlarge the subepithelial and submucosal venous plexus within the distal esophagus. The etiologies include disorders that increase portal hypertension, primarily liver cirrhosis. In fact, 90% of cirrhotic patients will develop varices, and it's most commonly in association with alcoholic cirrhosis. However, worldwide hepatic schistosomiasis is the second most common cause. On angiography, you can see these tortured dilated veins at the distal esophagus and proximal stomach. Patients are often asymptomatic until the varices rupture, leading to massive hematemesis and death. And for this reason, variceal rupture is considered a medical emergency, and half of all patients will end up dying.